Here's basically everything you know. Microdiscectomy done either through an open or a tubular retractor is still the gold standard for herniated disc. I'm done. No. So what do your patients want? Patient comes to you, what do they want? They want pain relief. They want early return to function. They want to get their lives back. They want it with a low risk of complications and a minimal chance of recurrence. So when you're talking about these procedures, this is what you have to answer. And it's really important to know that your patients do not know the difference between statistical significance and clinical significance. So I've been involved in MAS, in minimal access surgery, for over 20 years. I've probably abandoned more MAS procedures than I currently do because I look at my results and see what's improved. Remember that microdiscectomy is really the first minimal access procedure. Done through a small incision with enhanced visualization, magnification. This is a minimal access procedure by most definitions. So when we look at the evolution of MAS, late 80s, early 90s, all sorts of new techniques came out. And there were lots of different ways of doing things. By the late 90s, early 2000s, it was starting to get more widespread adoption. In the late 2000s, you would go to meetings and people like me would get up on podiums and go, in 5 years, every single operation we do is going to be done minimal access. Well, guess what? It's stalled. There has been virtually no growth in minimal access technologies in most markets in about the last 5 years. It's plateaued. Why is it plateaued? Well, resistance to change is part of it. Early adopters have already adopted it. And the old farts aren't going to change. But there's also studies showing inferior results for some techniques. Cost is an issue in a lot of places. But the key is, if you look at the long-term results of open versus MAS, there is no difference. Every study you look at that follows patients for more than a year shows no difference between open and MAS in long-term outcomes. So currently, if you look around, there's three camps. There's the never minimal access people, there's the always minimal access people, and then there are some of us, I'm in this category, that are selective. There are places where it's there. So what are the results of MAS surgery compared to open surgery? I'm not even talking endoscopic or transforaminal. This is just what are the results of open versus minimal access surgery. Consistently, shorter hospital stay, lower blood loss, less narcotics in the short term. But here's the interesting thing when you look at microdiscectomy or versus tubular versus open microdiscectomy. The studies that get quoted have length of stays of typically 1.6 to 1.9 days for the tubular retractors and 2.4 to 2.8 days for the microdiscectomies. In my institution, the length of stay for an open microdiscectomy is 2 to 4 hours. So how can I improve length of stay? If I get them out in 1 hour, is that a clinically significant difference? I put it to you that it isn't. There's no difference at 1 year. There's probably a lower infection rate with minimal access procedures. And I do believe that minimal access procedures are better in the morbidly obese. But I would put it to you, for most conditions, if somebody doesn't have a progressive neurologic deficit, why are you doing surgery in somebody who's morbidly obese? So comparing the translaminar and interlaminar discectomy, this is a procedure that we know we've been doing it for 50 years. It's got predictable results. It's flexible and extensile. So if we find the problem, it's easy to correct. If you get a durotomy, it's easier to repair. And when we look at comparing the open to the tubular, if you're going to do this, the tubular operation is the same operation as you've been doing. So when we look at what are the outcomes, again, these are two studies comparing open to tubular discectomy. Pain medication requirements were less with the minimal access. Hospitalization was shorter, but again, the difference was a day, not an hour. And because that's a hospital where the patients are normally staying at least overnight. Again, little lower blood loss, little length of stay, PACU narcotic use, but modest significance. But the real evidence is, what is the best available evidence when we look at all of this stuff? Well, there have been 2 systemic reviews looking at comparing open techniques, the open microdiscectomy, to tubular techniques and endoscopic techniques. and including one which is a Cochrane review, which is a very rigorous review of the evidence. And what they've actually found is that the reoperation rates, durotomy rates, root injury rates, and recurrences were all higher in the minimal access techniques. So when you're talking to your patient, they want a good long-term outcome. More reoperations is not a good long-term outcome. So what is the reality when we're comparing minimal access technologies for herniated lumbar disc? The reality is, yes, there's a smaller incision, but how much difference is a 1.5 centimeter incision and a 2 centimeter incision or 2.5 centimeter incision? Yes, it's shorter, but does that really affect outcome? The statistically significant length of stay that's quoted is meaningless in the current regime, at least in North America, of outpatient surgery. Very few microdiscectomy patients, open or endoscopic, are staying overnight. They're going home within hours. If you really look at the difference in estimated blood loss, your patient has probably lost more blood having their preoperative blood work done than the difference between an open and an endoscopic microdiscectomy. Faster return to function is probably more surgeon-driven. We tell our patients who've had MIS procedures, okay, you can go back to work sooner or back to activity sooner because I did a minimal access procedure. And part of the reason that I stopped doing minimal access lumbar discectomy is my recurrence rate was significantly higher. And I think part of the problem is that with the MAS, we may be letting our patients go back to activity too soon because they're feeling better. So the problem you have in comparing this particular problem, the more invasive the surgery you're trying to compare to, the more likely that a minimal access technology is going to show some improvement. But microdiscectomy is already a minimal access procedure. So it is going to be very different. So when you're looking at new technologies, there's always a burden of proof. We must start looking at value. Value is change in outcome over cost. With this era of constrained healthcare, if a new technology comes along that's more expensive, it has to give better results. The burden of proof is on the people with the new technology to show that they're improving value, better outcome, lower cost. And I would put it to you that to date, no MAS technology has proven to be better value, and that the people advocating for minimal access techniques have not met the burden of proof of showing that they provide better value. And remember that statistical significance is not clinical significance. Thank you.